So now we're talking about the myocardial infarction. Okay, so myocardial infarction when there initially there is a uh, ischemia, injury, and then infarction. The sequence of the changes are like this. There is a ischemia to the myocardial tissue, then there is injury, and then there is infarction. So if there is injury to the myocardial tissue, ST segment usually elevates within minutes of the onset of the cardiac chest pain. So there is elevation of the ST segments when there is injury. When there is ischemia, T wave inwards fully by 24 hours. So ischemia gives rise to T wave inversion, injury gives rise to elevation of the ST segments, and if then there is an infarction, then there is a pathologic Q wave that is more than zero point 0.3 seconds, or that Q wave might be one third height of the QRS begin to form in 1 hour. And if there is a old infarction, ST segments are normal, Q wave remains for well. So if there is old infarction, ST segments are normal, Q wave remains forever. Okay, so that are the things. So ST segments are normal and Q wave remains forever if there is old age. So if there is injury, there is elevation of the ST segment within minutes. Ischemia, T wave inwards by 24 hours. If there is infarction, then there is a enlargement of the Q wave. So sorry, deepening of the Q wave, and that is one third height of the QRS complex. And if the old that is infarct becomes old, ST segment comes down to the normal, but Q wave remains forever. Once the Q wave is deepened, it remains forever. So ST elevation myocardial infarction, there are two things: ST elevation myocardial infarction, non-ST segment myocardial infarction. ST segment elevation myocardial infarction often associated with the total occlusion. If you find that ST segment is elevated, okay, ST segment is elevated, so it indicates that there is a total occlusion. Some patients also develop Q waves. Okay, some patient also develops the Q waves. So ST segment elevation is often associated with the total occlusion. Non-ST elevation often associated with the partial occlusion. Non-ST elevation often associated with the partial occlusion, or it's a T wave inversion. So if it is a non-ST elevation, often associated with the partial occlusion. Okay, so two things: ST elevation always associated with the total occlusion. Non-ST elevation always associated with the partial occlusion or T wave inversion. So how to measure the T wave inversion is see the J point. J point is normally isoelectric. If J point is elevated, then there is ST elevation. ST segment depression. See, the J point is depressed. J point is a point where S wave ends and ST segment starts. That is the point that is called the J point. So that is the ST segment depressed. So abnormal T wave repolarization begins at the epicardium and progresses towards the endocardium, producing the T wave. So repolarization which begins at the epicardium and progresses towards the endocardium, producing a positive wave. This is a normal repolarization of the T wave. Abnormal T wave indicates myocardial ischemia and appear within seconds of the onset of acute myocardial infarction. These are caused by delay or change in direction of repolarization. Abnormal T waves are associated with the depression or elevation of the ST segment. Abnormal T waves are associated with depression or elevation of the ST segments. Normally, they are associated with depression or ST segment elevation. So changes during myocardial infarction. Where to look for the myocardial? If it is the anterior wall, okay, the lead effector are V2 to V4. If it is anterior wall, lead effector are V2 to V4. Vessels involve left anterior descending artery, diagonal branch. So ECG genes are poor R wave progression, ST segment elevation, T wave inversion. So in anterior wall, lead affected are V2 to V4, left anterior descending artery, diagonal branch. ECG changes are poor R wave progression, ST segment elevation, and T wave inversion. ST segment elevation and T wave inversion. So poor R wave progression, ST segment elevation, and T wave inversion. Okay, if you have anterior MI, you have septal myocardial infarction. This is V1 and V2, and left anterior descending artery, septal branch. R wave disappears. R wave disappears. ST segment rises, and T wave inverts. So R wave disappears, ST segment rises, and T wave inverts. So you see that there is rise of ST segment elevation and T wave inversion. So in lateral wall, that is lead affected are lead 1, AVL, V5 to V6, left coronary artery and circumflex branch. These are two arteries. It indicates ST segment elevation. If there is inferior wall, lead 2, 3, AVF, right coronary artery and posterior descending branch. Right coronary and posterior descending branch, T wave inversion, ST segment elevation. Posterior wall V1 to V4, left coronary artery, circumflex branch, right coronary artery, posterior descending branch. Tall R wave, ST segment depression, upright T waves. So I repeat once again. If there is an anterior myocardial infarction, lead affector V1 to V4, left anterior descending artery, diagonal branch, poor T wave progression, ST segment elevation, and T wave inversion. Septal wall V1 and V2, left anterior descending artery, septal branches, R wave disappears, ST segment rises, T wave inverts. Lateral wall, lead 1, AVL, V5, V6, left coronary artery, circumflex branch, ST segment elevation. Inferior wall, lead 2, 3, AVF, right coronary artery, posterior descending branch, ST wave inversion, T wave inversion and ST segment elevation. And posterior wall V1 to V4, left coronary artery, circumflex branch, right coronary artery, posterior descending branch, tall R waves, ST segment depression, and upright T waves. So in anterior wall, leads are V1 to V4, septal wall, leads affected are V1 and V2, lateral wall, that is lead 1, AVL, V5 to V6, inferior wall, that is lead 2, 3, AVF, and posterior wall, lead V1 to V6. You see the J point. Okay. Normally, this is a diagram showing how we confirm whether it is ST segment elevation or depression. The J point is isolatory. So J point is elevated, okay, rise from the baseline. This is the elevation of the ST segment. See, now this is elevated. This is elevation. Okay, this is again elevation of the J point. This is elevation. This is the depression of the ST segment. These are the J point again, elevated, but there are J waves. See, ST elevation, micro elevation. This is the how the elevated J point elevated. So ST segment got elevated. This is how the ECG tracing happens. ST elevation. So in infarction, what you are looking for? ST elevation, the and Q wave, deep Q wave and ST elevation. So how the ECG changes in myocardial infarction? T wave is the first to change and last to normalize. So T wave is the first to change and last to normalize. First T wave goes up. Hyperacute tall T wave. First T wave goes up. Hyperacute tall T wave. Then T wave goes down. T wave inversion. Okay. Lastly T wave comes to place. T wave normalizes. So first T wave goes up. That is hyperacute tall T wave. Then T wave goes down. T wave inversion. And lastly T wave comes to place. It is T wave normalized. Hyperacute T wave inversion, and lastly it comes to place. Next thing is ST elevation. Appears after T wave goes up. So ST elevation appears after T wave goes up. Normalizes before T wave normalizes. Normalizes before T wave normalizes. Q wave appears after ST elevation. Never returns to normal. So Q wave appears after ST elevation. So and never returns to normal, also seen in old MI. So first T waves becomes abnormal, that is it becomes tall, that's called hyperacute T wave, the T wave inversion, and T wave normalizes. Stimulation after T wave goes up, okay, and normalizes before T wave normalizes. Q wave appears after stimulation. Q wave appears after stimulation and never returns to normal. First is also seen in own myocardial infarction. So T wave, ST elevation, and Q wave. So if there is a myocardial ischemia, symmetrical T wave inversion or elevation, and ST segment elevation or depression. In myocardial injury, ST segment elevation or depression, ischemia, injury, and myocardial necrosis, abnormal Q wave. ST segment elevation is an ECG sign of severe, extensive, usually transmural myocardial ischemia and injury in the evolution of an acute Q wave myocardial infarction. ST elevation is considered if it is more than 1 meter above baseline and measures 0.04 second after the J point. ST elevation usually appears within minutes after the onset of infarction, usually indicating extensive myocardial ischemia and a progression to myocardial injury within 20 to 40 minutes. Then to myocardial necrosis in about 2 hours and the development of abnormal Q wave. So we will already discuss if changes are into the anterior leads, that is V1 to V4, it indicates anterior descending branch of the left coronary artery. Okay. If changes are in the inferior leads, the diaphragmatic lead 2, 3 AVF, branches of either the right or left coronary artery. If it is a lateral leads, changes in the lateral leads, that is lead 1, AVL, V5 to V6, circumflex branch of the left coronary artery. If changes are into the posterior leads, that is large R in V1, V2, maybe Q in V6, mirror test, right coronary or one of its branches. So in anterior leads, if you find changes, there is occlusion of anterior descending branch of the left coronary artery. If changes are into the inferior leads, branches of either the right or left coronary artery. If changes are into the lateral leads, circumflex branch of the left coronary artery. Posterior, if change, blockage into the right coronary or one of its branches. How to find the ST elevation? So you see, this is isolated ST segment. This is the ST segment elevation, and this is the ST segment depression. To draw the baseline, okay, passing from the TP or PR segments, anything above that baseline is elevation, anything below the baseline is a depression. ST segment depression, you see it. This is how you can find out ST segment depression. So ST segment elevation in myocardial infarction, there is hyperacute T wave. T wave becomes hyperacute. Then the J point elevation. Then this is the condition where you see the ST segment elevation. J point is elevated. Okay. And then the whole segment is elevated. Initially J point is elevated, then whole segment elevation. Then Q wave is formation and the loss of R wave. When the Q wave is formed, there is a loss of R wave and the T wave inversion. So hyperactive T wave, J point elevation, ST segment elevation, Q wave formation and loss of R wave and the T wave emergence. That's how the changes happens. Thank you.